We're going to move straight into the more exciting part of the evening, the future of primary healthcare. And it gives me great pleasure to welcome you all to this special event this evening. But before we get started, I will invite Yvonne Weldon. I can't see you, Yvonne. Yvonne is the chairperson of the Metropolitan Aboriginal Land Council, and she's going to give us the welcome to country. And following this, I'll hand you straight over to Professor Simon Wilcox, who's going to facilitate the rest of the evening. Thank you. Yvonne.
Good evening, sisters and brothers. As was said, my name is Yvonne Weldon. I am a Wiradjuri woman from Cowra, here in New South Wales. I'm from the waters of the Clare, which later became known as the Lachlan, and of the Murrumbidgee Rivers. I am the elected Deputy Chairperson of the Metropolitan Local Aboriginal Land Council, who are the culture authority under the Aboriginal Land Rights Act for the land we are on. I would like to pay my respects to all elders past and present, to all First Nations, to you, and the many nations that are represented online here this evening. Pay homage to the people of the Eora Nation, who suffered the first impact on behalf of all Aboriginal nations. Our boundaries are known and are lived through our interconnection across this continent, not from the roads and the man-made landmarks, but through the natural landscape of the earth. The Eora Nation's country covers the Hawkes River in the north, the Nepean in the west, and the Georges River in the south. My people have practiced our traditions for thousands of years and endless generations. One tradition shared in various forms across Australia is a welcome to country. It isn't a token gesture, it is a spiritual process, giving honour to the ancestors' footsteps we are all walking in. Continuing the practice of the many generations before us to the many generations to come. As you travel across this beautiful continent of ours, understand you're entering the lands of nations, tribes, lands that have existed here for over 60,000 years. My people are the oldest continuously living culture of the world. And on behalf of the Metropolitan Local Aboriginal Land Council, the elders and the members, I welcome everyone to the land of the Gamaragal. I acknowledge Gamaragal people whose spirits and ancestors will always remain with these lands, our Mother Earth. My people have always listened and learned from each other, the environment, animals, elements, and our ancestors. We don't live in isolation of body, culture, spirit, land and water, because we are one. We need to reflect upon the footsteps we're leaving to know where we're heading and bring about a positive future for everyone. Being here this evening for this important symposium, could you all please pause for a moment to remember the many sacrifices that have been made along the way, the ones we will continue to make, and those we shouldn't have to. Please reflect about those we have lost, the ones we need to continue to help, and so many that don't yet realise they may need you, and also you and what you give to others at the expense of yourself. Let's spare a thought for the families, the friends and the communities, and what we should do as a community of people gathered here this evening. So as you connect, learn and share today, tomorrow and beyond, know that everyone's health and social emotional well-being is more important than the material things in this world. Remember to reach out and provide support. It is an important step for you and the person you are assisting. If you don't, you may never realise the importance, what difference you can make. No matter what walks of life we all come from, all of us need to support each other, bringing out hidden heartaches to share and bringing us all a strength together. The road travelled alone is the longest, hardest road there is. Don't do it on your own. I will join you and you can join me. All of us together can bring about positive changes to each other and to this country now and into the future. To make that future possible, let us all draw upon my people's spirits as we continue on our journey. May my people's spirits walk with you and guide you as we strive forward for us all. Again, on behalf of the Metropolitan Local Aboriginal Land Council, welcome to Gamaragal land. This always was, always will be Aboriginal land. Thank you and have a wonderful evening.
Firstly, thank you, Yvonne, for that message, and thank you to the traditional owners of this land for sharing the culture and the traditions that have nurtured your institutes for 60,000 years, and also for your stewardship of this country. And I hope that we will be able to learn from that stewardship further to be able to fulfil the promises that Connie has committed us to. Nice to be back with all of you, both on screen and in the room here tonight. My name's Simon Wilcock, and I'm just going to facilitate. I'm not a speaker tonight. But I do want to do a few things before we start. Firstly, a couple of thank yous, particularly to our chair and our CEO, Kate and Linnell. That team has been working together now in leadership of the PHN for more than 2 years and have done an astounding job. And I would note that we have a nurse and an occupational therapist leading this astounding organisation at this time. It has made us inclusive, it has made us responsive to the issues, not just in our local communities, but in our larger world. So thank you both for that leadership and for that continuing leadership. Thank you also to Connie. You've already been thanked, but you're the Greta Thunberg of my generation, and you have taught us so much in the last 3 years on the board, and we all know that we will keep working with you because we will insist on it. Two other people who aren't here tonight, and I'm going off-piste here, but in the context of thank goodness we live in New South Wales. Kerry Chant and Gladys Berejiklian. What a year it has been, and haven't we been lucky that we've had those two amazing people leading us, not just through COVID, but through all of the associated disruptions of COVID. And given that we're meeting and our organisation is based in an area that is germane to both of them, I would like just to thank them for the leadership that they've shown us for the last year as well. For those of you that know me, you know I'm a bit of a storyteller. I'm just going to tell two very quick vignettes from today, from practice today. Two consultations that I did. Now, the first one was a telehealth consultation. It was a young man. He's younger than me, so I consider him young, but he was approaching his 40th birthday. He's had a number of health issues in the past, and he wanted to talk with me about some referrals that he needed, but also some things that he wanted to pursue. He and his partner run a very busy IT business, and it was difficult for him to get away. And of course, the telehealth that we've been allowed to implement in our practices over the last year or so allowed us to have a very good in-depth consultation. We agreed in that consultation, and we could review electronically correspondence from 5 years ago from a specialist, that it was a good time to go back to that specialist. So I said, look, I'll send him an e-referral. And within minutes after the telehealth consultation ended, pinged into my email, oh look, I've actually got an appointment today, otherwise it must have been a cancellation. He can't see me for 2 months, otherwise can you get a referral to him now? And by the way, I can't see him in his Parramatta rooms because he's going to be at his Eastwood rooms. So there I went, straight into the computer, could send a referral electronically. This is the sort of world, I've been a GP for a long time, this is the sort of world I've been waiting to practice in, where we can be responsive to the patient's needs, we can use the modern technology in a healthy, constructive way to help people. But there's still a long way to go, and some of that we're going to hear recommendations from our gifted speakers tonight. The second consultation I had, I didn't actually get to see my patient because she's 92 and she's in intensive care in hospital, not with COVID. And of course, I can't even go and visit her in hospital under those circumstances at the moment. Now, this lady's a lovely lady. She's been a patient of mine for the last 2 years since she moved into an aged care facility that I visit. She wouldn't mind me telling you that her name, she's known as Bonnie. She has another name, but when you get to know her after a while, you know why she's called Bonnie, because she's the most lovely, calm, welcoming, accepting person that you could hope to meet. She's actually cognitively in great health, but she's very frail. She has such a bad kyphosis in her spine that she sleeps in a chair. She can't actually sort of lie flat in a bed. And over that 2 years, we've fulfilled our obligations to the health system. We've managed her purely in her own environment. She had a little stroke a year ago, but she actually didn't need to be sent to hospital. We could do everything we could with some resources in the facility to manage her there. But about 2 weeks ago, she actually developed a significant medical problem that after 5 days, we agreed we couldn't manage in the aged care facility. So I arranged with the local hospital for her to go there. I sent lots of documentation. I said, we need to sort out this problem while she's there. And I suggested she needed to see a surgeon. She probably needed to see some continence nurses. She had a very bad persisting prolapse. And of course, then the nightmare began. We organised transport, but I wasn't aware that apparently the ambulance people can do an ED online consultation, and that person who's never met the patient can actually say, no, she doesn't need to go to hospital, and cancel it. So next time I checked to see if she was there. No, she's still at the facility. Manage it in the community. This is not easy with somebody who's very frail and difficult to mobilise around, whose family actually live in the Southern Highlands. Anyway, we eventually got her to hospital, and again, I spoke to everybody and I pled with them. I said, please, can we do these things while she's there? I know it's not a good time to send people to hospital, it never is, but we've sort of done what we can in the community. Anyway, 36 hours later and she was bounced back, and I got a few apologetic phone calls from a resident who was an ex-student of mine saying, look, sorry, but we've organised for her to see a surgeon in a couple of weeks, and we couldn't do anything about the continence stuff, but she's going to see the continence people in 3 weeks too. And then we found out that because she wasn't seeing them in hospital, she had to pay $250 to see the continence people as an outpatient. Anyway, the evening before she was due to see the surgeon, and the family were still wondering how they were going to get her right across Sydney to see the particular surgeon she'd been booked into, she got up at night because of her problem, fell over and fractured her neck of femur. We're also familiar with that story, so now she's actually back in that same hospital in intensive care, and I'm not sure she's going to get out of there. We had the opportunity to collectively and in an integrated way deal with this lady's problems, and the parts of our system that don't talk to each other didn't allow us to do that. We live in a time where we've got technology at our fingertips, where there's so much more that we should be able to do for our patients in the community. So it's a very apt time to talk about the future of primary health care. In the very broad context of primary health care, which is health services that we deliver at the front line in the community. And that's what our panel are going to talk about tonight. I think in parallel with the adoption of new technologies like telehealth and the need to disrupt some of our health service models during COVID, there's been a recognition that some of the rigid linear care algorithms that have been developed, particularly around sort of critical care and acute care situations, don't actually allow for those complexities of care for people in diverse communities and individuals. Some of you will have been aware of this document that's out for discussion for consultation at the moment, although I'll get that in a minute. I think the consultation closed yesterday, called Future Focused Primary Healthcare, Australia's Primary Healthcare 10-Year Plan for 2022 to 2032. And the speakers tonight have been asked to speak to some of the recommendations in that particular document. It's actually good. I think for the first time it actually recognises the important roles of parts of healthcare other than medicine. There are extensive sessions on not just allied healthcare generally, but specific other health groups that provide services in the community. But our challenge is going to be to get the implementation of those recommendations in such a way that we actually can manage our patients. I love hospitals, and even though I'm a GP, I've always had an affiliation with a hospital. I've always been either employed or had an affiliation, been able to walk in. And I think hospitals do critical care and very acute care really well. My observation over the years is that they do complex integrated care of particularly frail elderly or people from other medical disadvantaged groups very badly, because they actually don't have the resources to provide that integrated care. And it's an opportunity for us to do in the community. I'll finish by talking about the quadruple aim, which I'm pleased to see they've modelled this particular document on. Many of you would be familiar with the 4 pillars of the quadruple aim. I like it because it's only 4, and if things go up to 7 or 8, I can't remember them all. But just to remind you, 4 things are important. Whatever we do in health and whatever we think about for our communities, those things have to improve people's experience of care, not just their outcomes, but it actually has to be a good experience for them as well. We have to improve the health of our populations, and we can only do that if we use interventions and treatments that are based on good evidence and contextualised for the relevant populations. They have to be cost effective. We want to spend, it's not about saving money, it's about getting the maximal value out of every dollar we spend in healthcare. And we've got North America as a great example in the United States, where they spend double the health spend on healthcare, but don't get as good outcomes as we do because of some of the complexities of their system. And finally, and this fourth part of the quadruple aim was only added in after they thought of the third part, but very relevant to us here tonight, improving the work life of healthcare providers, because we have to be the sustainable part of the system to make the rest of it work. If we're burnt out, if we're looking to do something else because it's too hard, you don't have a primary healthcare system. So I'm excited. I'm also recognising that I'm coming to the end of my career, whereas many people in the room, including our newest board member Daniel, are at the beginning of their careers. So I'm looking forward to our panel now discussing their perspectives on the future of primary healthcare. You've all got this sheet here which tells you about the speakers. It's in very small font, so that gives me an excuse not to try to read it all, but I am going to briefly just introduce the speakers that are going to speak from now on. And my only role now is to facilitate, and then we will have plenty of time at the end for questions. In the order that they are on the program, but not necessarily speaking up here, Julie McCrossan AM is well known to many of us from her media and broadcasting career. And she was treated for stage 4 oropharyngeal cancer in 2013 with 33 sessions of radiotherapy and weekly chemotherapy. In addition, she has spent 15 years as the primary support person and care coordinator for her late mother, Marjorie. So from a consumer and community perspective, nobody better to talk about primary health care. Professor Ian Hickey, many of you will have heard speaking on the media regularly. He has a wonderful ability to bring mental health and the complexities of mental health service provision to us in a way that we can understand and can also understand what's needed. He's the co-director of Health and Policy at the University of Sydney's Brain and Mind Centre. Now, Ian's going to have to, as Julie will be, is going to have to do a Zoom presentation this evening. And we've got a mixture of about half and half with Zoom presentations versus the presenters being here. Very reflective of the year we've been through, and also reflective of the composition of the audience tonight. Dr. Kirsten Meisinger is our international expert who's going to present again by Zoom tonight on patient-centred medical homes and healthcare system transformation. She's been National Faculty Co-Chair for the Centres for Medicare and Medicaid Services, an initiative which transformed over 140,000 US practices to value-based patient-centred medical care. I did a study tour 2 years ago when we could still go overseas to the States and looked at some of the wonderful things that they are actually doing in primary care. So even though it's an expensive system and a lot of that relates to their health funding and insurance mechanisms, there are some fantastic initiatives that we need to borrow and learn from. Siobhan Conn, who is here with us tonight, is an accredited practicing dietitian, accredited nutritionist and health coach. And she's Director of Discovery Health Coaching and Director of Accredited Health Coaching Australia. I think Siobhan is representative of the sorts of health careers that I hope we're going to see the next generation adopting, where people actually will come out of the traditional silos that we've been trained into by our disciplines. We've all received good training, but there hasn't been a recognition that people really need to have a range of skills and be able to develop the skills that are relevant to the particular environment and community that they're working within. And my long-term colleague and friend, Professor Charlotte Hespy, who works in clinical general practice in inner city Glebe and as a principal of a 16-doctor group practice. She also is the head of general practice and primary care research for the University of Notre Dame School of Medicine. And very importantly, she's currently chair of the RACGP, Royal Australian College of General Practitioners, New South Wales and ACT faculty. And you've probably heard her speak many times this year, particularly in the context of COVID. So Charlotte's actually our first speaker tonight, so I'm going to invite Charlotte up to speak to us. Each of the speakers has 10 minutes. I'll give you each Oh, Patrick. Patrick's not on the list here. Patrick, no, he is on the list. It's just my old eyes and the picture. Sorry, Patrick. So Patrick is a renal physician, and again, wonderful to see people who are talking about traditionally hospital-based specialist services, but within a community context. And Patrick is nephrologist and general physician working on the northern beaches of Sydney, and a University of College Cork Ireland graduate, so we'll have that unfair advantage of all speakers of having a lovely Irish accent. Charlotte, thank you. Now, I will give each of the speakers a sort of 1 minute warning. We're going to try to keep the speakers to time. They could all speak, I'm sure, for half an hour, but we want to have plenty of time for questions from the audience, and we'll hold questions until the end. Please remember to post your questions online, and we'll also take them from the audience as well. Thank you, Charlotte.
Thank you, Simon. And thank you, everybody, for... I was so excited when I got invited to come and talk to you tonight. And it's live. It's pretty scary at the moment, can I say, and pretty weird. So, yes, hi, I'm Charlotte. I'm unapologetically a GP, and a clinical GP is my joy. And how fortunate am I to say that my career is been a joy the whole way through, except the challenges of our funding system. So we'll come to that, because being asked about the future of primary care, why? You know, why are we even having this conversation? Why are we even thinking about, does it have a future, or what does the future mean? Simon's beautifully talked about some of those reasons already, covered a lot of grounds of which I could have talked about. But I think I'll just start on, for me, that the big premise around why primary care is because we know internationally and in Australia that countries that have a really strong primary healthcare system have much better health outcomes for their general population. And the joy of general practice is not just about the power that I have as a GP about the patient in front of me. It's about the power that we have to actually help and influence our community around us. And that's just a transformational thing. But we're also really cost effective. So countries that actually have the best healthcare systems, again, have primary healthcare systems because they're actually cheap. Now, that doesn't mean we don't add good value, but we're so much more cost effective. I mean, I really struggle with why the government doesn't pour money into general practice and primary health care when you consider that to see me and have a problem solved and or use a whole lot of the services that are wrapped around us in my practice still only costs Medicare $37 and whatever it is cents. Don't ask me. I try not to keep out of the finances a lot of the time. Yet if I send them down the road to my hospital because we're unavailable, it costs $350 and nobody blinks an eye. And yet that's funded. Can I say, in the ACT, they actually think that's how they do it. They use a model of care that is so much more expensive, and it gets justified somewhere. And beggars belief. And I'll use COVID as the classic example. I think there'll probably be a few GPs around who might be along with me at being incredibly insulted by the federal health minister's announcement last week of, oh, wow, we're getting $25 added on to the cost of a consultation if we see a COVID positive patient live in our practices. Woohoo! You can have COVID in your practice and you get $25. It beggars belief. And do you know what's even worse is that if you actually look at all the models of care that actually are around really good, well-developed, evidence-based systems of how we're looking after our COVID positive patients, is it in the flesh? No, it's not. It's by telehealth. It's all done virtually. And if they actually do need to be seen face-to-face, they actually go to a hospital or they get seen in a respiratory clinic that has actually got the right systems in place to make sure that everybody is absolutely looked after at the same time. And do you know what? They spent a lot of money setting up GP respiratory clinics, and they get a lot of money to see patients. So how insulting that they should tell general practice, who's been doing a bloody good job, I say a bloody good job, of doing all the vaccinations, again, at not even half the price. We'll go lower than that. If I actually look at what our wonderful New South Wales health system, can I say they're wonderful? I love working with Kerry Chant. She's the best person ever. She's a doer. She's an enabler. She's never a blocker. She gets general practice. But she's not in charge of the funding. If you go into a vaccination clinic in the local health districts, they have a lot of people behind the scenes and running the system to actually get a vaccination done. In my practice, we get through a vast number for much, much cheaper. No one really talks about the economics of the different rollout and who's been most effective at doing it. It's been us. Okay, sorry, I'll get off my bandwagon about why we've been unrecognised, but that's all of the primary healthcare system. We're great, we do a fantastic job, and we're really we've been undervalued. That's why we're having the discussion. Do people actually recognise it? Yes, there's actually documentation. Right back from 2011, I got one out about saying the case for change. We have to actually do something and reform the way in which we're funding and supporting general practice. Same time, guess what happened? They stopped actually paying GPs very well. And you know what? It's been really interesting. We used to attract 55% of medical graduates into general practice. Currently, we're attracting 15%. Is that not tragic when I've just talked about the absolute value, the joy of actually being able to do good patient-centred care? Well, I haven't actually talked about patient-centred care. Better get quickly because I know I'm going to run out of time. I'm terrible. I get talking too much. So what is the value of where the health reforms are? It's actually going to be around trying to incentivise certain things that really do add value to patient care, and that is true patient-centred care. Can I say that is not what people talk about when they go to hospital and say they're getting patient-centred care? That's still a system-centred care that has a patient that they're talking about. Okay, so I can talk about it as a doctor, oh, I'm delivering patient-centred care, but the patient has to come to me, they have to do this, they have to do all that, and it really doesn't matter what their needs are, but I'm still delivering patient-centred care because I'm looking after a patient. Of course that's patient-centred. But it's not, you know, where we can actually start talking about what is it that the person in front of me actually needs. A lot of the time it's actually about the social prescribing care. I know that the biggest change in people's lives that I can bring about is not about the medicine that I prescribe on a piece of paper. It's actually about the social requirements, meeting their needs as a person, hearing what they need to say, responding to their needs appropriately, being able to actually then help them find what solutions it is that we've got to do, whether that be about getting financial advice, whether about seeking how to get the hole in their roof sorted out, how to actually, you know, get some of those services into the house that they actually need. Or for a lot of my elderly patients, even just logging onto the computer now and getting their damn vaccine certificate so that they can actually go and talk to people. Or shopping, yep. You know, well, I've got an 88-year-old mother who it's taken me an awfully long time to actually teach her to take her mobile phone to the shops, have it charged up, how to actually turn it on and then scan that thing on. And I've had a hallelujah chorus the last 2 weeks. She's done it 4 times. But, you know, those are really big and challenging things, and it's not, and we sort of take it for granted that it's easy, but it isn't. And who does it with a lot of people all the time? It's a lot of the time, for me, it's about the role of the GP and the services that we can help provide doing it. So of course we're cost effective, of course we need to do it, but that's where it comes to the integrated care, is that, you know, I'm talking, as I said, unapologetically from my experience as a GP, but I know that I could do so much better if I actually could integrate properly with all the other services that I need to actually sort of talk to. And I'm starting to see it a bit like Simon was saying, the joy of being able to do telehealth and meet the needs of someone who, you know, really might not otherwise have actually visited the doctor because it was too time consuming to take out of their day. I'm being able to do electronic referrals. I can do e-prescribing. Who doesn't love e-prescribing? I love e-prescribing. I'm trying, and if we're talking about carbon footprint, isn't it wonderful to say I'm not doing any paper? No paper, really mean no paper. It's going to be it's going to be emailed and it's going to be sent to your phone. But then, of course, we've got the carbon footprint of the phone, and then they have to turn. You know, we won't go into that conversation, but yep, 1 minute left. So, you know, in terms of being able to actually integrate, it's actually being able to have a system that is funded, not just the GP. That I obviously know the experience of what that looks like, which means that we've turned away all of those other graduates, because why would you go and be so unvalued? Because the government doesn't value you, then, well, nor does our profession actually either, in terms of our other colleagues often don't. But in actual fact, what we actually need to do is be able to have a system that encourages us to talk, to communicate. I just love it when we actually get together and be able to share the experience. When I can tell the accident and emergency, the sort of my experience and the story, and help someone navigate their journey through, at the same time as then facilitate the right services at home, and they don't get sent home and then actually bounce back to hospital because nothing was there for them. Again, very similar to Simon's telling the story, and I'll leave at that point because, yes, he's right, I could talk for half an hour and bore everybody pieces, but thank you.
Thank you, Charlotte. And I'm sure there will be many questions and many more opportunities for you to share that. Another thing I forgot, it is my age, was to thank our sponsors tonight for contributing to the cost of the evening, but also for having their support for primary care in the community. And in particular, our most significant sponsors, who are Genesis and AstraZeneca. Thank you very much to the representatives tonight. We're now going to cross to the US, I think, Kirsten, who's online there. I've already given your introductory spiel, Kirsten, but feel free to say anything more that you would like about yourself before you share with us the wisdom of the US.
I will assume that that's an ironic statement. So, good evening, everyone. It's such a pleasure to be part of this. Can everyone hear me? Oh, I can hear me. That's terrifying. All right, I'll carry on. So, it's such a wonderful honor to be invited to contribute to healthcare, which, as everyone knows, in Australia dwarfs in terms of value what we provide in the United States. So I will try to simply focus on the things that we have experimented with and that have actually worked, because in our world, things are so bad, you might as well try something. And so you do have a very strange day-to-day in the United States where you have these amazing experiments that have been run in real time and sometimes fail, as experiments are wont to do. And then you actually have some wonderful successes. Because I do really appreciate being in Australia to almost sort of detox my very ineffective healthcare system, I have thought often about how can we take some of the lessons that we've learned in the United States and apply them elsewhere in the world, Australia included. So one thing I would just pick up and reflect is that people change slowly, systems change even more slowly, and culture changes even more slowly than that. So I have become a more patient person because I have spent my career doing change in the medical space, and increasingly in the community as well, because as I think we'll hear tonight, really people as humans operate in their lives. They don't operate in a GP office, and they don't operate in a hospital, pun not intended, because those are places to be honestly avoided, right? I know I certainly, when I go to any GP office, even as much as I appreciate and am one and love what I do, I know very clearly that somewhere in the back of my mind, when I arrive as a patient, that I'm sort of convinced that they're going to tell me I have 6 months to live. And so the euphoria I feel upon leaving is palpable. And I try to bring that to my interactions with my patients as well. The sense of vulnerability that our patients have when they're in our care, I think, is always paramount in my mind. And one of the things that we have learned in this journey with the reshaping of care in the United States, called the patient-centered medical home, which is an odd term, but it's been around for 20 years, so we're probably just going to have to leave it be, is that to be able to really intersect with other parts of the healthcare system, and even more importantly, the social prescribing parts, as we just heard, probably some of the best ways to do that is to start working in a team and involving your team members. So in the United States, because we are fabulously wasteful, we had all sorts of people sitting around, and it was not entirely clear what value they brought. We've always had a role of, you enter the practice and you have a receptionist, and then you actually have a special sort of medically trained person that brings you into the room, and then I arrive magically. And because Australia, again, you guys really do things better in almost every realm, you don't have this extra person, but we did. And so we looked at this person and said, the receptionist has a relationship with our patients. This medical assistant, which is the name of that person, that role, also has a relationship with that patient. And what we found in my clinical environment, which is actually which is predominantly people from other countries, are that we actually hired receptionists and medical assistants from those same cultures and languages that we're serving. And so those relationships actually became very close. And using that relationship to actually have the patient feel loved, honestly, and cared for from the moment they walk in, has been part of the building of what we call the patient-centered medical home. And what that allows me to do is time, which is the ultimate commodity, to deeply think about what are the things that I need to know for you, my patient, as you walk in. What also are the journey what's the journey you've been on between last time I saw you and this time? And COVID has given some curious gifts. In our system, the gift now is that I can trace all of your footsteps. I have an integrated medical record across the whole of Massachusetts, the state in which I practice in the United States. And I can literally see everything that you have done. I can see every lab result. I can see every radiological result that you've had. I can read the thoughts of the other providers caring for you. And that has been amazing. But I do need the time to look at that and integrate that without becoming a hero and working way past what is sustainable. And team has actually been part of that answer. And funding for team has also been part of the answer. So I would encourage you in Australia to look at some of the principles of the patient-centered medical home as a way forward for you to get time, and for the GP, time and experience with direct relationships with patients for your staff at the GP offices, as well as ideally Australia really working on this integrated, seamless connectivity electronically. And I know that New South Wales is actually a leader in this in Australia, which is also why I love working with New South Wales. That kind of ability, and by the way, in my experience, patients have always assumed that we knew all of that. And it was a bit, I think, shocking and disappointing to them that I wouldn't be able to just guide them across their journey in the entirety of the healthcare system, because that is our job, right? As primary health providers. So I want to also just include another team member that we haven't explicitly talked about as a member of the team, but the patient in our patient-centered medical home is actually a team member. And we, in my practice, actually have patients we try to have two who are actually on our work groups and our leadership, and actually literally guide us as they experience care. We have tried to integrate this across other elements of the affiliate organization I work with, work for, Cambridge Health Alliance. We have actually integrated them into our information technology work group, so that when we rolled out telehealth, we actually had them next to us telling us, and continue to have them next to us telling us what matters to them, what are the things that are a priority for them, how to make that journey to just go shopping easier. How do you get your vaccination card actually in a way that you can have it on your cell phone, right? Just as we heard, these kind of life-changing, I think, aids and attention to things that really matter to the people we serve are part of this philosophical change within the patient-centered medical home, and then actually extending past it, of bringing patients on as true equals and true partners in our care, and actually taking a patient from our own practices, not necessarily a patient representative, who are also very important, and I work with many of them, but they're not going to know where my practice is not yet meeting the needs of our patients. And bringing our patients in as equals and partners is a lovely reframing of medicine's hierarchy, which I find to often be the primary source of why we can't hear the voices that we need to be the loudest. So I'll pause. I think I'm pretty much at time. I don't know if there's any other points that folks would like me to touch on. I've tried to limit what I could say to the good bits from the United States. There are colossal failures. We can always touch on those in the questions, but I think that might not be a good use of time. I do just want to say, in preparation for the conversation about psychiatry, that is probably the team member besides my patients that I would sacrifice last. So I'm so excited to hear what Ian has to say, because the idea that somehow the mind and body are separate has always seemed mysterious to me. And I'm glad that we're uniting them on this panel. Thank you so much. And I so look forward to the conversation and discussion to follow.
Thank you so much, Kirsten. I couldn't agree more. I think one of the things, and I saw many things in the models when I was on the study tour in the States, but one of the things that really excited me was having the in-house psychologist and the idea of doing warm handovers and actually sharing information about patients instead of jealously guarding it, which often happens on both sides at the moment. So thank you for that, and I'm sure there'll be questions. I can see Ian on the screen now. Condolences to you, Ian, and thank you for making yourself available tonight. I've already introduced you briefly, but you probably don't need any welcome, any introduction to the team here. So I'll let you start on your presentation.
Thank you, Simon, and thanks for the opportunity. I am coming to you from the lands of the Gadigal people on the other side of Sydney Harbour of the Eora Nation, and I'm very grateful for the opportunity to actually live and work on these lands. It's a great pleasure to follow Kirsten. I did have the pleasure of working in the United States in the early 1990s, where I first came across the concept of medical homes. Didn't quite know what it meant, sort of mixed it up with nursing homes and other things, but actually somewhere in a community that was focused on coordination of care, particularly for chronic and difficult diseases, and really did emphasise staying out of hospital, but solving problems. To pick up one of Charlotte's comments, problems getting sorted out, not the single problem getting sorted out, but complex problems getting sorted out. And that requires teams of people to operate in operation. Now, the mental health areas Kirsten just alluded to is a classic of that. What sets of skills are actually available to sort problems out? We don't often actually sort problems out. Even the best of the primary care systems I'm associated with, and I've been the director of Headspace, the National Youth Mental Health Foundation. If you go to the Medical Journal of Australia this week, you'll see data we produced about 2 years out of outcomes, where 2/3 of those young people coming for care actually are not functionally better 2 years later. We have a lot of contact with people, but we often don't sort things out. I often talk about really the structure, the infrastructure of healthcare these days is two things: skilled people and smart technology to coordinate their care specifically to the needs of people that they are seeing in the initial assessment, in the coordination of care, and with a strong focus on measurement-based care on an ongoing basis. I often say to people every day, a rather odd thing for a doctor, I don't really care who gets better, I care who doesn't get better or who gets worse. That as we move along, that we respond to the complexity, we actually respond to the changes in the situation as they take place. I'd like to try, I've just found out that the host is disabled screen sharing. I was going to share with you some documents from the World Economic Forum, which I'm associated with, as Global Future Council on Mental Health. As Kirsten just
go now if you want, Ian.
All right. Okay, thank you. Sorry, I didn't warn the organisers quite about this, as I was hoping to be there with you live. I'm hoping that you can see that. Now, I come to the World Economic Forum, not the World Health Organisation, okay, and not the World Professional Organisations. These are the guys and people who invest in healthcare, running social ventures, etc. Back in 2016, they talked about fundamentally the future of smart healthcare, efficient, patient-focused, delivering outcomes at good cost and at scale would depend on actually the smart use of technology, which has already been available for a long time within the healthcare industry. Let's face it, the healthcare industry is fundamentally resistant to the use of smart information technologies. We are incredibly siloed and separate. Patients might assume that we know what's been going on in all the other parts of their healthcare system, but we don't every day. In mental health, the World Economic Forum, and part of this, has taken forward the real huge challenge in mental health, that the demand for services worldwide is huge, but the supply is very low. And a lot of the quality of care provided is very low. And that integration that Kirsten just talked about of mental health and physical health, your healthcare is your healthcare, mental and physical. And in many communities, many people understand that it needs to be addressed at the same time and as an integral part of healthcare. But many of our physically focused healthcare systems and many of our short acute intervention-based systems have never dealt with mental health care systemically. So the World Economic Forum has a focus on actually 8 billion minds. How do we use mental health technologies as part of regular healthcare actually to coordinate care on an ongoing basis? So the discussion I have with doctors every day of the week when it's just digital healthcare is they've usually got in mind really clunky electronic medical record systems, really clunky standalone prescribing system, really stupid, not personalised apps, and the notion of technology that adds to the burden of their day. In other words, horse and cart stuff. Largely what used to be paper and pencil turned into a computer or an electronic thing. It might save paper, but it doesn't save time. It isn't coordinated. It isn't person-centric. It isn't person-facing. Kirsten just alluded to empowering people to be partners in healthcare. If I say one thing tonight that matters, that's it. Empowering people and their families to be partners in everyday healthcare, what they can self-manage, what they can take care of, what they can do in partnership with healthcare providers. What I'm tied up with in the development of technologies in this area is hopefully what's the equivalent of an A380. It does stuff that a horse and cart just can't do because it allows people to do things in complex ways. The biggest supporters of all of what we are doing in this moment in mental health care, but also in aged care, I might say, and in child and youth care, is at the user end. They want systems that are empowering, that are engaging. My own kids refuse to get involved in my health record through the Australian government because it's not their health record. They don't interact with it. It's something done by governments, poorly coordinated, probably creating incorrect information that they don't trust. They're used to using all sorts of systems every day of the week where they interact with those systems. They add information, there are feedbacks and there are loops where they are part of those systems. In the mental health area, they allow people to take that forward. These are systems we need embedded in medical homes, in the primary care system, wherever the most coordination of serious healthcare, like the two cases that Simon discussed at the start, is being coordinated fundamentally from its place in the community, not through a large hospital, which for 3 days would not do much and then send the problem back to you. It's very popular with communities and families. In the mental health area, families talk all the time about being disenfranchised. When I was on the National Mental Health Commission, they complained the most about a lack of information, a lack of coordination of care, and a lack of coordination of mental health care with physical health care. It's clearly attractive to funders in this area because you can see who's doing what. People say they're doing stuff, and you can see potentially the outcome, not just the activity, and the maximum use of skilled professionals in these particular areas. For clinicians, you have the opportunity to use real-time data to deliver effective care and actually get the best outcomes for the individuals over time in complex situations where not just you, but a whole group of people may be doing things on an ongoing basis. And for us, that's a really important set of issues. I was going to show you one additional slide was, if you thought it was hard before COVID, the situation actually now, this is from the Lancet just this month, is the mental health situation, demand far exceeded supply pre-COVID. The pressure on primary care, on emergency departments and others will significantly go up because the demand for services on estimates has gone up at least 20 to 25%, and most of that is primary care. And when primary care fails, it ends up in emergency departments. And what we've seen in New South Wales for young people is a 45% increase in presentations to emergency departments during that period, i.e. we don't have primary care systems that can cope. And what we're just doing through New South Wales data linkage studies is the percentage who represent to emergency departments, 30% within 28 days, 50% within 3 months, 75% within 1 year of representations in the system. Our systems have never been built to coordinate this, and a simple clinic-based approach is never going to work. So my challenge in people, and just one final comment about where real healthcare costs are actually going. Suicide rates in Australia continue to rise, and although we did a good job of containing this last year with economic and social benefits, for young people it's particularly problematic on an ongoing basis. And just to remind people, go backwards here, that the largest cause of premature lives lost in our community is suicide. 115,000 years of premature life lost every year, far in excess of ischemic heart disease or cancers or other metabolic sets of conditions. But I just say, do we have the time? Do we have the effort? Do we have the systems? Do we have the teams of skilled professionals to provide services to start to reduce that biggest cause of premature life lost? It's also, of course, mental health, the biggest cause of disability, particularly in working age groups, 60% of disability in 15 to 34-year-olds. And the situation for young people in Australia, as is the case worldwide, has deteriorated over the last 10 years prior to COVID and is now markedly increased in the COVID era. So the challenges are huge. I'm really glad to see that document about the future of primary healthcare teams. Strong emphasis on teams, strong use of technology, but let's face it, that's not what we currently do. The leadership for this won't come from governments. The leadership is regional. I'm a big advocate of regional issues. The issue for the PHNs, and I see the question is, who is going to lead this? Who's going to do it? And I'd suggest in Northern Sydney, you have the resources, you have the application. And so the question I would ask of the audience tonight is, are you up for the challenge?
Thank you, Ian. I agree with you completely on your sort of analysis of where the system needs to go. Patrick, I won't forget this time. Thank you for sharing your perspective of the future of primary care.
Thank you very much. Thank you all for having me. Thank you to the Primary Health Network for inviting me. I think this is probably the first such event that I've attended in recent months where I'm not wearing my pajamas, which is a nice change. I think it's really interesting that there's been the same theme across all of the speakers so far, which I'm just going to really summarize, because it's, I'm almost redundant because I'm saying what has already been said repeatedly by all the speakers to date, particularly Simon with his second vignette regarding the elderly lady out of hospital, back into hospital. I really wish that I shared Kirsten's patience. She said that, we change slowly. We are a very, very conservative profession. We change slowly, and systems change even more slowly. And Kirsten calls for patience, and that she has become more patient as she's become older. I wish I became more patient as I become older. I think before I start whinging, I think I should remind ourselves that, just what a fantastic job we do in Australia on a day-to-day basis, looking after patients. I come from a country where I was a medical student in the second half of the 1980s, and I trained in the first and latter half of the 1990s. And really, you know, the care that was provided to our patients in Ireland was really very, very significantly inferior to the care that we provide in this country. So let's not forget the fact that we're not perfect, and we never will be, but we do provide very good care in Australia. So what can we do to improve the level of care that we provide to our patients on a daily basis? I think we need to remind ourselves that back in the 1980s and early 1990s, the patients that we were caring for are not the patients that we're caring for nowadays. The patients that we're caring for nowadays are significantly older. Now, admittedly, I'm hospital-based and community-based specialist, and so I'm only referring to really a portion of the patients that you're looking after. But we really are looking after very elderly patients with multiple comorbidities and a very high level of complexity, which didn't exist 30 years ago. I didn't see these patients when I was a medical student. They didn't exist. The level of cognitive impairment is higher also, and health literacy is variable. Some people have very good health literacy, but it's not always there. A lot of the patients that we're looking after, certainly that I'm looking after, they see more than one GP. Sometimes they're attending GPs in different practices. I've had arguments with patients. I'm thinking of one guy in particular, you know, just trying to get him to go to just one practice. Honestly, that's right. He attends the Vale Medical Clinic, and just 20 metres across the road, he also attends Warringah Mall Medical and Dental Centre. Anyway, so they attend multiple GPs. A lot of the patients that we see are already seeing multiple specialists. You know, they're seeing Joe Soap for their heart, and they're seeing Patrick Coleman for their kidneys, and they're seeing someone else for their lungs, and so on. And so they're seeing multiple people, in addition to seeing multiple GPs. They're having their tests done in a whole stack of different laboratories. They're going to Douglas one week, they're going to Laverty another week, they're going to ACL another week. They're having their imaging done in multiple different places. They're all taking vast numbers of medications. They have no idea what those medications are. They don't know their names, they don't know their doses, and they don't know what they're for. And they come to see us without knowing what they are. And unless we insist on them bringing their medications to every single appointment, we will never know. We will never know what they're taking. And so what we're dealing with is what all the previous speakers have alluded to, is that we're dealing with a really, really fragmented medical system. Not just primary care, but across the board. The health system is incredibly fragmented, with all these different aspects working in isolation. Communication is appalling. Coordination of care is worse. There is no integration of the care that we provide to our patients. This leads to a massive waste of time. How many in this room and out in the stratosphere waste vast amounts of time just trying to suck information out of the ether, just trying to piece together a history on the patient. A patient who frequently has poor health literacy and cognitive impairment. They can't give you a history. You have to find a history yourself. It's wasting our time, it's wasting our patients' time, because they're having multiple tests that they don't need, because they already had the same test last week done by someone else. And it's wasting their carers' time, their family members' time, getting dragged around to different appointments and different locations for different tests. None of us have enough time. Everybody in this room and out there is agreed. 24 hours in a day is never going to be enough. And yet we're wasting vast amounts of time just trying to get information on our patients. So there are huge inefficiencies in the system, which is really a crying shame, because we have a really good health service, which is well resourced compared to many other countries. It's a shame. Why don't all GPs have global access to what I have? I can just log on to Douglas Hanly Moore, ACL, any pathology lab, and I can look up anybody's blood test result. But I gave a talk in Ryde a few months ago, and I heard that you don't have that privilege. Apparently, I'm special. So, thank you very much. What are the solutions? I think part of the solutions are that correspondence needs to improve. Basically, encrypted correspondence, I just can't believe that everybody doesn't have it. But heaps of specialists don't have it. A lot of GP practices have only just started using it. It makes no sense. Argus, we spent $550 last year on Argus. We spent $4,620 on stamps. My health record is potentially going to be fantastic. Kirsten said that in Massachusetts, she can get any information on a patient that she wants, that she's looking after. What are the barriers? The main barrier, and the barrier in relation to the patients that Stephen was talking about, and everybody else talked about as well, is that when they go into the hospital, you don't get anything back. You're getting no information, particularly from your specialists. I look after incredibly complicated patients with kidney transplants or on dialysis. They've got multiple comorbidities. And I'm sending copies of my letters to all these different specialists that the patient is seeing, and they don't reciprocate. They don't send their copies of their letters to me. It makes no sense. There are other barriers, or practice managers just put it into the too hard box. The bureaucracy involved in just signing up for my health record is a nightmare. It needs to be improved. Finally, I would make the point that they're not my patients. They're your patients. When I'm writing a letter back to you, I start every single letter with, I reviewed your patient, or thank you for asking me to see your patient. And so, if you're not getting good quality care from your specialists, stop using them. If they're not communicating adequately with you and the other caregivers of that particular patient, there are plenty of other people to use. To the primary network, I say, you need to lobby more effectively for your members. You need to lobby more effectively with hospitals and specialists in particular. The communication between hospitals and primary care is abysmally bad. It is appalling. Am I right? It's getting better. But it has been appalling. And so I think I'll leave it there. I think there's plenty of room for improvement. But I just think that we need to get more clinicians on side. I mean, to have clinicians telling you, oh, it's too hard, or I don't know how to use IT and all the rest. I'm a dinosaur in my mid-50s. I still type with 2 fingers. If I can do it, anybody can do it. I mean, seriously. Thank you very much.
Thank you very much, Patrick, and I think some great points made there. I think actually in primary care we can actually be very proud of advances we've made in practice management. I think our practice managers in primary care have actually made it a profession, and there's been quality improvement that's gone on for decades now. And certainly I notice the difference often between practice management that I see in the community versus in specialist situations and in hospitals as well. Our next speaker is Siobhan. And as I said earlier, I think Siobhan epitomises from her biopic there what I hope is going to be important in the future. And I talk to medical students all about the time. You actually have to develop a career that maps against what your clients and what the community need, not what your college or training organisation tells you it should be. Thank you.
Thank you. Welcome, everyone. So, yeah, thank you for the opportunity to represent the allied health workforce. I feel like I've got quite a few people on my shoulders tonight. It's the second largest health workforce, obviously, in Australia. And I'm also obviously incredibly diverse, as we know, too. I'm also representing health coaches. You probably would have seen that on my bio. And I'm a professional member of something called Health Coaches Australia and New Zealand Association. So this is the new association in Australia and New Zealand that is regulating health coaching. So there is a number of providers now in Australia and New Zealand that are training up GPs, nurses, health professionals, and as we call it, the health passionate, but they have a different pathway, obviously, to become health coaches. And one of the reasons that I got into this field, and I did 10 years ago, was because I was trained as a dietitian and I was trained all about nutrition and how to educate people, how to diagnose, educate and prescribe with meal plans and food and whatnot. But as you all probably have experienced with lifestyle-related conditions, it's not enough. Telling someone what to do, providing the strategies or solutions, giving them some more and more education around what's bad for them and why it's bad for them and why they should change. So I got into the field of health coaching, a behaviour change approach. And it took more than just doing a motivational interviewing course on the weekend or a little bit of training. It's actually a really complex training where we go through a specific set of skills and it takes a lot of practice. However, it has been life-changing and career-changing for me to also be a health coach as well as a dietitian, and all the health professionals that I've come across, the GPs, as I said, the nurses, the allied health practitioners that are also health coaches. Because once you have that training, you have that real patient-centred care. So Charlotte was talking about it before, and I used to think I was collaborative by saying to people, okay, so will those strategies work for you? And someone would nod or just be like, okay, yep. I've checked in with them, so I'm collaborative. But it's completely different, that collaborative style of care and that patient-centred style of care. So I'm going to go into that a little bit later, but I'm here to obviously represent that as well, and also an interdisciplinary perspective to this conversation about the future of primary health care. So we talk about multidisciplinary, but we don't talk as much about interdisciplinary, which is us coming together and working together as all the different disciplines. So I'm not sure how many people in the room know of the Australasian Society of Lifestyle Medicine. Give me a show of hands. Ah, yay! That's great. So I'm a member, and I was a previous board member of the Australasian Society of Lifestyle Medicine, and it is about collaboration between us all. It's medical health practitioners, about 50%, and then the other 50% is allied health practitioners, nurses, academics, public health professionals, all working together as a movement to create change to prevent, treat and manage lifestyle-related diseases. So in terms of, I guess, the future of primary healthcare, and I think what the steering recommendation said, and I think what we all want, is that empowered patient-client who is not passive in the system, but is in control of their own health and is an active participant, and that we're all working together to support that person. So we've said this before, and I feel like I'm repeating myself, it's not working in silos, which obviously we've heard about all the problems that we're, segmented and we're working in silos and whatnot. And GPs tend to be sometimes a one-stop shop, which, in my interactions with GPs, there's a lot of burnout, and that's because there's a lot of pressure put on the GP. So my vision really is that there is much more of that support throughout all of the allied health practitioners and the GPs and the nurses, etc. We're working together. And I guess we've seen a little bit of us working together in some clinics, but we need to be working together a lot better, as we know, in the online space, and I think digital healthcare is going to play a huge role for us all connecting. I think it sounds really exciting, the steering committee's recommendations, the VPR, and hopefully with the sharing of patient information, with them choosing one, again, as Patrick was saying, is them choosing one GP and one practice, and also having coordinated care within that practice of allied health practitioners as well. It's also obviously getting local, and the PHNs, as you said before, have a huge role to play too. The other thing is referring early on in the process is really important for allied health practitioners too. So often I get referred clients that have many complex conditions, and sometimes I'm actually the last stop. So they'll often say to me, I've tried everything, or I don't know, it's been years and I have this and this and this and this, but I finally thought I'd, agree with my GP and see the dietitian. And that, when you're an allied health practitioner and someone's on a chronic care plan and they only have 5 sessions per calendar year of 20 minutes, and you're sharing that with other allied health practitioners, it's kind of hard to create health behaviour change. So that's sort of another point that I'm going to bring to in terms of increasing the funding model. But when you're getting clients earlier on, it is actually easier to create change and prevent chronic diseases and lifestyle-related diseases. So that's the first thing, is being really proactive as an allied health practitioner and as a GP. So as an allied health practitioner, I do see people, and I'm always thinking who else could support them in their care. Lots of people I see are more preventative, or they come to me with sort of early lifestyle-related disease risks. And I'm always thinking, okay, who else? Is it a psychologist? Is it, referral back to their GP for further testing? Is it EP, exercise physiologist, etc.? But being proactive in that early referral on, I think, is absolutely key in us supporting people to keep them out of, obviously, hospitals and getting too far down the track with chronic diseases. I alluded to before the funding model. So the future of primary healthcare is obviously reforming a funding model, and I think for allied health it is really, really important. We need more allied health to bulk bill, and we need to reduce the gap for patients, and that means increasing the MBS fees. And for some of us, as I said before, there's just not enough time. And those 5 20-minute sessions isn't enough time. So, in terms of what we could be offered, can we be offered more time than 20 minutes? Is there more funding for a longer initial consultation? There has been some progress with NDIS and home care, etc. And I'd love to see that further enhanced. I'm actually a mobile practitioner, and there's not many of me. Actually, before it was trendy, I was doing Zoom consultations and phone consultations. Now I'm just, one of the mix. But I'd really love to see more sort of funding and support for allied health to be mobile. Some of us are, but it makes such a huge difference in some of my patients' lives. I have a lovely DVA client, and I go to him and we go for a coastal walk together. He hates the sterile four-walled clinics. He doesn't like to leave his home, but he does meet me down the end of his road for a walk. And he says at the end of the consult, he goes, "This is like the best part of my day. I feel so good. I feel so much more motivated in my care. I'm going to go back to my GP. I'm going to connect with these health professionals." And that's the difference I find, in doing something that's a little bit outside the box. So I think, the future of primary healthcare, it's about flexibility. It's about meeting our clients' needs so that they get the best experience from our healthcare system. Also, I've alluded to the behaviour change approach before, and I feel like every single health professional needs to be properly trained in this approach. I think we all need to have health coaching training or proper behaviour change training, and also potentially, because this is starting to happen, health coaches employed within our clinics. So there's some properly trained health coaches at the moment, you'll find them through HCANSA, that are starting to be employed in GP clinics, and that takes the burden off the GP. It's a low-cost model too. Yes, we don't have Medicare item numbers for health coaches yet, but watch this space. But they still come in at a fairly low fee. So it starts from $26 to $28 an hour for a health coach. That's where it starts. And the actual, obviously the billing on top of that can be higher. But it actually is a really good system to take the pressure off. And as we said before, when you've got 15 minutes for a consultation, it's hard to create behaviour change. It can be done, but you need some more support. That's where our allied health around you, plus some health coaches in there to help you with behaviour change, I feel is the answer. I think I can't talk any longer, can I? Sorry. I've got more to say, but maybe on the panel. Thanks.
Thank you so much, Siobhan. We would love you to talk longer, but we need to let our final speaker speak as well. But yes, I think we're all looking forward to further questions and answers. And as the partner of an allied health provider who runs a purely mobile practice, I agree with you completely. And our final speaker on the panel tonight, again, is known to many of you, Julie McCrossan, well known for her media and public work, but also for some of the journeys that she shared with us in the past around her own health journey. So is Julie? Yep, I can see you up there now, Julie. Over to you.
Look, thank you so much. And I'd just like to begin by thanking you for having a patient and family perspective as part of the conversation about the future of primary care. If I could ask Jordan to put on my first image, and I'm drawing on two particular experiences. I was treated for stage 4 oropharyngeal cancer in 2013, tonsils, tongue and throat, with 33 sessions of radiation therapy and weekly chemo. The other experience I'm going to refer to is my experience as the sort of primary family support person for my mother and a care coordinator in partnership with her general practitioner. And Mum was one of those people with very complex care needs and a passion to not go to a nursing home. And she was able to stay at home until just 3 weeks before her death at 94. So if I could go to my next image, which shows me behind the mask. I had radiation. When you have head and neck cancer and radiation, you have to wear a mask. But these are members, just some of the members of the multidisciplinary team that saved my life and managed my recovery. I'm 8 years since treatment. But before I refer to the cancer, I just want to give my 5 foundational pillars to the future of primary care. And I think it's going to echo many of the excellent comments that have been made by my fellow panel members already. So my first foundation is time. In the future now, I want time with my general practitioner to build a therapeutic relationship and partnership. And I want time so that a family member of the patient or a nominated friend, so a nominated family member or a nominated friend can also develop a relationship with the general practitioner, and I'm mindful, obviously, of the very significant number of people like myself. I'm 67, the ageing population. Relationships with our health team heal, and long-term doctor-patient relationships heal the best. My second foundational pillar, which I believe will address immediately many of the issues that have been raised while we get together digital skills and other things, is specialist nurse coordinators based in general practice, people who will ensure that everyone effectively communicates with each other, acting as liaison connectors and being responsible for the development of shared written care plans that are regularly updated and shared with all key players. I've seen this work so well in cancer. It's a model we can use in the community. My third foundation are funding models for home visits for general practitioners, and sometimes they're designated representatives, but I don't think there's any substitute for general practitioners coming into the homes and the residential settings where we actually live. Of course, I'm talking about general practitioners who wish to do this, but our funding models should enable and support general practitioners willing to visit us and not be barriers and disincentives to them doing so. My fourth of the 5 foundations for general practice and primary care is that general practice needs to be financially and intellectually attractive to medical students. I was alarmed by Charlotte Hesp's 15%. I'd love to know the source of that figure, 15% of medical students choosing general practice. Is that a national figure? I'd love to know more about that. But we need funding models that are an incentive to choose general practice, not a disincentive. And finally, and I had to add it because it seems so obvious I didn't need to say it, but I'll say it as others have said it. Our final foundation is that primary care is a team multidisciplinary sport, and the funding models just have to catch up. So I'll quickly share 2 personal stories involving general practice that teach 2 very different lessons about the future of primary care. So I'll start with my cancer story. As I've indicated, I won't, there's no time to run through here, but there is a dietitian, there is a nurse, there are 3 different kinds of doctors, there is an administrator, there is a practice manager, there is a radiation oncologist, medical oncologist, and surgeon. And these are just some of the people who spent 5 years, because that's when you're let go by hospital-based teams, saving me from a stage 4 oropharyngeal HPV-related diagnosis. And I had fabulous multidisciplinary care. Could I just see the next slide, please, Jordan? This is radiation treatment in the mask, 33 consecutive days. Another time, if you'd like to hear more about this experience and the role of general practice in trying to get us identified and referred to ear, nose and throat doctors earlier, I'd love to give that presentation. No time now. Next picture, please, Jordan. I tried, this is again a multidisciplinary group. I'm trying to represent what does this patient-centered care look like? How do you convey a concept to the health people who lack literacy? And this was my attempt. But I genuinely felt a range of highly skilled people were working together and communicating well to get me well. And the key to it was a very trusted and respected nurse coordinator. But the critical message about my cancer experience is that my general practitioner, and I'd been at the same practice for something in the order of 20 years. I come from a medical family. I know the importance of consistency. My general practitioner was not a member of my cancer multidisciplinary team. He wasn't given the information he needed to play a meaningful role, nor was he invited to play any role whatsoever by the hospital-based team. And this was intensely true for the 2 months of preparation for treatment, the actual treatment and that acute recovery treatment. And many of you may know that head and neck cancer is famous for being a particularly tough cancer. And in recovery, we have the highest suicide rate. It's a tough gig. And my general practitioner was not involved. But what was really extraordinary to me was that he was not involved in the 5 years of care that is involved when you are a cancer patient under our current system. Yes, I've just seeing what I've written here, but he just was not involved. But of course, eventually the hospital disappears and there I am with the general practitioner. This failure to inform and include my GP in any meaningful way fundamentally undermined our therapeutic relationship. Dentists are also utterly crucial for head and neck cancer patients. No information of any kind was presented either orally or in writing to my dentist. The only contact my dentist had was with my surgeon because I personally asked him to do so. And as a favour to me, he spoke to my dentist. I don't have time to explain to you, but a dentist not fully informed about the needs of a head and neck cancer patient who's had radiation could inadvertently do great trauma, leading to necrosis of the jaw. I've made videos about this in 2021. I'd love to share them with your PHN. So thank you to my surgeon for ringing. My dentist nearly fainted because he'd had other head and neck cancer patients and he'd never had contact with the cancer team. So lesson number one, we need to formally include general practitioners and dentists in cancer teams. We need cancer recovery plans after cancer treatment, like immediately after, that outline the key recovery goals, identify the clinical team members who are hospital-based, general practice-based, and in the community. We need to specify their primary role and responsibility and provide their contact details. And the recovery plan needs to identify potential risks for the patient, including symptoms of recurrence and side effects of treatment that need to be monitored and addressed. And the plan should provide links to up-to-date articles and information so that all the team members, including the patient and family, can inform themselves. And I particularly want to thank a representative from the United States, Kirsten, and also Ian Hickey, who mentioned the family. All my treatment was as an outpatient. The vast majority of my mother's care, and I'll turn to that now, was as an outpatient. My wife at the moment, who's in this home with me, fell 3 weeks ago off a wall, has 10 broken ribs, a smashed collarbone and a broken thumb. She's had 2 brief hospitalizations, and I am here caring for her for at least 8 weeks, fully responsible for taking her to all appointments and managing a complex range of mainly opioid medications. You know, GPs and family are in this together. Very quickly, my second story is completely different around general practice. My mother's general practitioner was a true partner in care. She was a partner to my mother and to me as the primary family carer. Mum's GP truly cared, and she had a therapeutic relationship with my mother, so she involved me in order to support my mother. She identified me as I suppose, a key asset to my mother. My mother's general practitioner did regular home visits. She guided me to transform, and if I could see the next photograph, please. This is me and Mum. My Mum's GP guided me to transform Mum's whole home effectively into a nursing home. That isn't the beautiful antique bed my mother loved. That's a very expensive hospital bed with an air pumping mattress that prevents bed sores. My mother was in bed for 10 years. Became a very frail person. She was in a nursing home for 2.5 weeks and she got her first bed sore in 2.5 weeks. I don't have time to go into that, but my Mum's GP and I were a fantastic team. Could I have the next picture, please? This is again in Mum's home. It's not a hospital, it's a home. Could I have the next picture, please? The GP assisted me to get a whole range of mobile allied health, as I will now call them after our last presentation. Here we see a physiotherapist who kept my mother walking. Mum dreaded going into a nursing home, and that physiotherapist and her home visits, combined with the carer behind and many other professionals who came into that home, saved Mum from her fear. Today is the 11th of November. Do I have to tell a group of Australians it's Remembrance Day? My late mother was in the WAAF, the Women's Auxiliary Air Force, in World War II in Britain, and she met my bomber pilot father at a Bomber Command Air Base in Britain. My mum was a war bride. She came out on one of those ships after the war to Australia, and she had 2 traumatic periods of institutionalisation. In the late 40s, she had tuberculosis. She had one of the first heroic lobectomies and was away from her growing family for a year. You know, a very, very tough experience. In the mid-50s, after my birth, her third of 5 children, she had a nervous breakdown, and she had another over 18 months, it was, in a mental hospital with very large quantities of ECT before muscle relaxant. My mother was left utterly traumatised and had a dreadful fear of institutions, and hence her dread of ever having to go to a nursing home. And my mother's GP understood that. She took the time to get to know my mother and her history, and she worked with me to keep mum at home. So lesson 2, general practice is not funded properly to help old people stay at home. I'll just quickly mention the Royal Commission into Nursing Homes, but this was before COVID and before the Royal Commission that my mother had this need not to go to a nursing home. My mother's general practitioner did hours of pro bono work for my mother. Pro bono was a flashy Latin word for free, and I don't have to tell an audience of general practitioners about free work, and probably the other multidisciplinary and allied professionals who are with us tonight. But my mum's GP did a ton of free work for my mother. The current funding model does not support this work in a sustainable way. And I noted that something like 50%, wasn't it, of the patients in your primary health network were qualified as old patients. My mum's GP was run off her feet, and I will be grateful until the day I die for that general practitioner, just as my mother was grateful until the day she died. My final slide summarises my key points. I won't read them again. Let's go to the panel, and I'll offer this PowerPoint for distribution. Thank you very much.
Thank you very much, Julie, for sharing those stories with us. Those of our panel members who are in the audience, I think, are going to come and join us here. And I'm going to try to facilitate some questions, both from the screen but also from the group here as well. Okay, so these ones have been answered already, or?
Well, Kirsten has, but I think it might be good for the rest of the audience.
So just to read a couple of questions that Kirsten has already responded to. Please campaign to increase payment for item 23 for GPs prior to the federal government. Well, I think that's something that we can all take for granted. Well, we can all agree with. And it's not just, of course, about standard consultations for GPs. It's investment in primary healthcare service provision, not just in medicine, but in all of the services that many of our speakers have spoken about. Another question, coming out of the COVID pandemic, does the panel think the changes induced telehealth, etc., will be positive or negative force for ongoing transformation? Will there be a desire to revert back to the safe and comfortable? I see many practice owners grappling with this. Charlotte, I might let you take that one.
Great question. And I think there's we all tend to go back to what is safe and what we're used to. And what I found actually really interesting with the telehealth was the lack of adoption of video. That GPs are used to using the telephone. We've used the phone for years, never paid for, and it was a hallelujah chorus moment to actually go, wow, all this work that I do unpaid, I can finally get some reimbursement for it, and isn't it great to be able to do it? But that real added value is actually in the video. And I think it was such a disruptive time. A lot of people found it was hard to get the cameras, to get the setup, to find a system they were comfortable with. And so by that stage, a lot of people, I think, stuck with the phone rather than converting to what, and again, I'll say it, is the best thing since sliced bread is the video aspect of telehealth. And so Therefore, I don't think the adoption of what is really helpful going forward happened in the way that I would have liked to see it. So I would encourage particularly anyone who hasn't gone yet into the realm of the adoption of that they do, because it's brilliant. We forced our patients into it. I confess, by actually sort of saying, we're not going to give you a phone call until you've tried the video link. And it was really successful. So now the vast majority of our patients, even my very elderly, use the video and love it because they get that face-to-face contact, which you don't get with the phone. Will we revert back? We will, unless we actually adopt into video, because we'll go back to normal, because telephone doesn't have that same connectedness, and we all know it. You're exhausted if you're doing consults just by phone, and you can't do it. But there is an opportunity to really, really amplify what we can do and how we care for people and meet people, our patients, where they need us if we adopt telehealth in the way in which I think the system should be able to do it. Can we get it funded properly? I think that the video will be funded properly and the telephone will fall off. So that is also a risk.
I don't think we'll lose it, because I don't think the patients, the communities in Australia will let the government take it away. But so we need them to shout that message if they agree. But Kirsten, you wanted to comment on that as well.
Yeah, I just want to complement that, if that's all right.
Yep.
So I agree that as a clinician, the video is vastly superior to the telephone. And I remain curious about the use of telephone, because we would have abandoned it if it weren't helpful before telehealth. I think that we may be going into an era in which we can complement in person with these other technologies, whereas during COVID, everything disappeared and we had to use whatever was available at the last moment. So also, I would just like to bring forward the voice of our patients in telephone versus video. There are real equity concerns and patient concerns about letting people into their homes. That is something that not everyone is comfortable with. Psychiatry in our system felt very strongly that video had to be the modality, and yet we actually have wonderful evidence-based studies showing that telephone consultation for mental health is as effective as video consultation and in-person consultation. So I guess my voice here is just to say, let's be careful to listen to the people on the other side of the video or of the telephone and co-design with them so that we are not making decisions without their voice.
Thank you. And can I reiterate, absolutely, there's a number of patients, obviously, who and we need to have the telephone as well. But if we don't use video more, we run the risk of losing the phone as well. And can I say, it's so much easier to just use the phone than the video.
It's such a critical question at this stage of the evolution of health service delivery that I might see if any of the other panel members want to comment on that role of enhanced technology in providing services.
Yeah, I'd love to. I agree with everything you said, Kirsten. Kirsten. Sorry, I should know your name by now. and I think that there's a role for, the face-to-face, the home visits, the video conferencing, and the phone. And I think in my experience, clients have wanted to see me face-to-face initially, whether that's in a clinic, whether that's home visit, or whether that's through video. And then they're sometimes more comfortable to go to phone. Not all of my clients are in Sydney too, so obviously we've had to do video conferencing and phone. But also because I'm always thinking about what is going to be the best thing for my clients, I'm always encouraging them to walk if they want to, and it's very easy to do that when you're on a phone call. So my clients might go for a walk by the coast while they're having a great chat to their dietitian and health coach, and they feel like, yep, tick tick, I got my cardio in, and I had a chat with my health coach and dietitian as well. So. Yeah.
Julie, I was very taken by your comment about time. because it reflected what I've learnt in practice. I insist on an hour with every new patient now, unless it's something really trivial in a young person like a wart on their finger. Because I know that the more I get to know a person, the better our opportunities for effective communication in the future, and that when we trust and know each other, we can actually use a whole lot of technologies very effectively. But did you want to expand further on that point?
Well, I guess I'm interested in how much money you get for the hour. Do you just do a proportion of that and you just take it as a cost yourself?
It keeps me sane. As I get older, I waited for years to be able to see that 30 patients in a day, and I never got there. But my life is much more satisfying, and my time with my patients is much more satisfying, and I think it's much more satisfying for them. And I actually don't lose money doing it.
Look, can I just say, rather than me answer that question, because I think more time is a self-evident truth. You obviously are going to get a deeper understanding and build a better therapeutic relationship if you have time. What I'm interested in is there any hope on the horizon with these reforms that are being discussed that there will be a change of funding model? Because I have a daughter who is in her late 20s, who's a GP, and the pressure she was under to whack through these 15-minute meaning, what is 15 minutes? And people say, well, it's better than the old 7.5 minutes. What is 7.5 minutes? I'm a professional interviewer from the ABC. I don't want to get you on for 7.5 minutes. I want a good 15. And that's I'm talking that in a journalistic. Kirsten, please tell us the benefit. But I want to hear from you. Why didn't you mention the family? Why just the patient? Surely out in the community, we family are as much carers as doctors, more so. But you go.
So, so Julie, it's so funny. So in the United States, GPs are called family medicine. So the family is always in my head. I apologize for not bringing that forward intentionally.
You only patients as being involved as representatives in your governance.
So I think the telehealth technology allows family voices to be even more central. I also think as we center care around people, they will bring their family in, and who they decide their family are, as you so beautifully said, in a much more intentional way. So I don't actually feel like I need to champion that. Once patients are truly partners, they decide what matters to them. And if family is important to them, which it often is at many stages of life, then that enters the room as well. I effortlessly care for the entire family at the same time. So frequently I will actually have an entire family of 5 or 7 in one room. COVID's put a little bit of a dent in that. So I would say you're absolutely right. Thank you for the very valid point, and for helping me realize that, family used to be the way I referred to everything, but COVID has made us go back to the onesies and twosies. I would just say, in terms of the ability to give us time as human beings, there is something coming that I think is coming, but I am not Australian, called enrollment, which will actually allow us as people to decide who needs more time and who needs less time. So I actually have done something very similar where we now have 30-minute visits, 30-minute consults for everyone. I don't need 30 minutes for everyone. What happens in reality is I take an hour for some people, and then I take 15 minutes for others, particularly younger folks who, when they're not in a mental health crisis, and I absolutely echo Ian's, I think, anxiety, rightfully so, about the state of mental health in particularly our 20-somethings who spent much of the pandemic entirely socially isolated, or our teens who spent the pandemic in abusive families and could not get away. These are the folks coming to me in complete disrepair. What I would argue is we now have an ability to decide, of the patients who need us more, because hopefully we don't need our GP to the extent that your mom did for most of our lives, we will then be able to spend more time with them, because in a dedicated relationship building way, that you did intuitively, but is not intuitive for so many people, as we heard. I know I'm acting like I'm from Australia. You very much, and we do as well in the United States, need support, structural support, to build relationships and to have the time to make those relationships meaningful. And it is important with your GP. It is important with your team, whoever you decide your team is. It should also not be decided by the healthcare system who your team is, right? Patients can decide who they love and who they want to work with. And so I think what I'm saying is there is a mechanism in place to be able to do that. And I have to stop talking now and defer to people like Charlotte, because I don't really understand what enrollment means. I just know it has this potential.
Could I just say very quickly on the family point? I've just been in 3 different clinical locations in the last 3 weeks. So I'm in a real life crisis in the family at the moment with this major injury. And it happened just as it did so often with my mother. I don't get identified with my partner. I'm not named. I'm not welcomed. There is no eye contact, and you are not actively involved. And then that person, you pick them up in the car and you take them home with the prescriptions. And my interpretation, because I think what is happening to these human beings, that they're not acting even in a courteous manner. And I see it, and I'm very interested in our kidney specialist view on this, but that people are so overburdened and under such pressure of time, they can't afford to give eye contact to anybody but the patient, because they cannot take on a psychosocial dilemma. They fear that it'll be more time consuming and I won't be able to manage it. It's my only way to understand it. And that's why I've come to see the value of the nurse coordinator who's given permission to have more time and to liaise. But I don't know if one of the GPs or our specialists wants...
I might let Patrick respond, and I would comment that COVID has been a great facilitator of allowing yourself to ignore everybody else other than the patient. And then I'd be interested in your perspective, Ian, because so many of these things are tied up with social and mental health.
I cheat. You can't hear me. Can you hear me now?
Yes, no, just if you could speak up. I've had cisplatin, if you know what that means.
I cheat. I get up very early in the morning and I log into Power Chart from the public system, EMR from the local private hospital, the local databases, the pathology labs. And so by the time I see the patient, I already have a very large amount of information on them already. And people frequently ask, oh, can my husband come in, or can my son or daughter come in, and so on. And I always say, of course, the more the merrier. I think that the people that I see, particularly the more complex people that I see who do really well in the long term, are the people who have a carer at home or very nearby, who's really invested in their care. I see a lot of people with cardiorenal syndrome, so a combination of kidney disease and heart failure, and I give them all a document that I've put together called Staying Out of Hospital. And I get the family member to weigh the patient every morning or a few times a week. And I teach them how to adjust the dose of the diuretic to maintain the weight at an ideal level. And we keep them out of hospital that way. So it's very much a team approach. It's very much a, I don't know if that answers your question or not.
Thank you. Thank you.
Thank you. Ian.
Yeah, a few comments. I get asked all the time, what do you do if your doctor doesn't see families? So get another doctor. I mean, you can't afford in any part of our health system to not have your own advocate. The main advocates are families, the main people who act to try and keep information together in our non-digital systems are families trying to keep some degree of continuity. What's been interesting in the COVID era, and I think with some of the technologies, particularly the video technologies, is actually the greater engagement of families in their own home, in their own time. One of the things we've also seen in the youth area is greater participation. Far less did not attend because actually the timing and the place was far more convenient. The person's home is getting to your clinic and fitting in with your schedule. So on the, is it going to go backwards? No way, because the patients aren't going to take it. Actually, a whole lot of people actually much prefer the flexibility that comes with the systems. On the video versus telephone is complicated. And the mental health area, I argue, it is complicated for more complex cases and certainly for first assessments of the value of video. But the trouble with the thing, and much discussion at the moment, that is simply a replica of the ordinary practice in time and efficiency. It misses an earlier point that I was making about genuine empowerment and rapid information trading in real life times from patients and families with health systems and back again, that promote self-care, that communicate changes in status, really interactive systems, not just replicating with phone or video what you were ordinarily doing. These are systems that are much more engaged and people expect responses in real times. And that's not so much a time thing. In fact, there's a lot of time saving things. I'm personally saying with a whole automated system tracking new medications or what is happening or problems that escalate the problems that need to be escalated to those with greater skill quickly. So they actually triage a lot of things. So if a really, particular type of professional, a doctor, a pharmacist needs to get involved, they get involved immediately. You're not back on a waiting list again, waiting with a whole set of problems to turn up to a 15-minute consultation or a 30-minute consultation. That problems are getting sorted in real time to avoid hospitalisation, to avoid deterioration and get escalated. And they're scalable. They're scalable. So it doesn't actually have to be done by the receptionist. They're smart systems. I just, as an aside, was involved myself in a system monitoring 20,000 people for suicidality, something I could never do on my own. But actually a series of smart systems, guess what? I'm the one clinician behind it. And actually, I end up having these email conversations with people who say, I've never had a conversation with someone like you ever in my life before. I never got through the system. There's a whole lot of other systems behind that. And actually, that means I actually spend a lot of time with a small number of people who really need to spend a lot of time with. And I don't spend a lot of time with a whole lot of people who got their problems answered long before they needed to see someone like me. So I think we've got to get beyond. I mean, Greg Hunt made the comment, we had more change during COVID in 10 days than we'd had in the previous 10 years towards telehealth. Telehealth is digital health, 0.1. There are whole big systems that have moved on, which are information technology systems, like we use every day with our phones in finance and trading and everything else. They're much more interactive and they're much smarter in the use of clinician time than just replicating clinician times with telephones or video.
Yeah, and I would just add to that.
We're running up against our end point, but Kirsten, there's one more specific question directed to you. So I'm going to ask that question, and then you can respond and make that perhaps closing statement. So the question from Chris Boland is: could you please explain how much the extra person on the patient-centred medical home team improved the delivery of the quadruple aim, especially the provider experience it's needed in Australian general practice at the moment? I have seen the model and I have seen James Jersak and the Bellin Health model in action. It is so important for the audience to know it's possible in a fee-for-service setting.
So I would caution that last statement. I actually don't, it's possible for a short period of time in a fee-for-service setting, but people get tired because it does still require what I'm hearing everyone here say, which is you're all heroes, and that is not a compliment. Because heroes, unless you are actually immortal, get tired and retire early.
I did my PhD in burnout in health professionals, and yes, being a hero is not good for you, a health hero.
Exactly. So capes aside, I would say the most important change that we made is allowing patients to have more than one relationship. So to answer Chris's question and to also complement, I think the point that Julie is fearlessly making us address, and I love this about her, is the way technology and the way team interface now is much better than before. So I actually have an 82-year-old father, and I will frequently take his secure patient portal email, which interfaces directly with his providers, and knowingly, right, use his voice, which is total, right, which is a total family hack, right? So I'll misspell one or two things just because he's not a terrific speller, and make sure that I have some ability to converse directly. And the system that we have here now in Massachusetts, and this is not just at my health system, it is now universal, is that you can actually get care without appearing for care. And this is not something Australia does better. It's exciting to have finally found something that I do better than you guys. We actually have secure email in your own chart that goes to any of the specialists that you are being cared for, but primarily it goes to the practice nurse. And that is because the practice nurse is the best person to respond kindly and quickly and with additional questions, not a pat answer that makes the patient feel dismissed. That extra person is actually necessary and is a benefit to the patient, because I am honestly busy running around seeing people, which is a great role for me in a practice. And yet they still need to have someone they can ask a question to. And when the nurse knows that the question has gone beyond their ability, they simply, and I'm actually in the conversation the whole time, I see it afterwards, I then just compliment that. That is team. Another form of team is to Chris's point, having that extra person so that I don't flip immediately from person to person. It's very stressful to go through 30 lives. And that is what you're seeing, Julie. You're absolutely right. If I walk in the room and I see an absolutely engaged family member and my heart sinks, that's a system problem, right? That is not a human problem. The human being in me is ashamed at the end of the day, but that is not us as people failing our patients. That's the system allowing us to fail our patients. And we don't want that. So we become heroes and then we retire early, probably to the North Shore, which is one of the most beautiful places in the world, by the way. I just want to say a little shout out to you guys there. It is spectacular.
Could I just say,
we'll allow
I
you
promise,
that closing comment.
could I just make a 30-second comment? Because that reference to the alarm, if you see the family member, where that's different is if you're a discharge planner and a middle-aged woman comes to visit an old lady in a hospital, then you're everybody's friend. So sometimes they see you and sometimes they don't.
Patrick wants to make the last comment, and I think given his accent, we should allow him to. We haven't addressed the issue of patient enrolment, but I suspect that's something that we actually are going to need to run webinars on. It's such a critical issue, and it is going to define a lot of what happens in the future. Before we go to Patrick, have you got the 20-second grab, Charlotte?
No, I just want to note that patient enrolment is actually just about continuity of care, and actually having GPs know who they're responsible for so that they can actually provide this higher level care that we actually know is associated with better health outcomes. Under our system currently, really, most of us put in different definitions about, is it someone who's been in 3 times in the last 2 years? Is it someone who's been around once in the last 5 years? Who do I actually own? And so am I responsible for making sure their healthcare outcomes are good?
Can I just say, I need to say, because I've sat through this meeting, that as a mental health GP, patient enrolment is going to be majorly problematic for my patients. And I'm sure as a mental health GP, patient enrolment is going to be majorly problematic for my patients, and I'm not alone. There are many other GPs.
It's going to be a two-edged sword, and I was going to make that comment. I think we need special sessions just on the implications of patient enrolment. Patrick, definitely.
But just remember, but you've said it, Margaret, it's the continuity of care that's important, and you're providing that.
It wasn't a comment, it was a question to Kirsten. Kirsten, since when have you had this integrated system in Massachusetts? What is it called, and how long did it take to really get it to work? Because the uptake in Australia has been really, really abysmally poor, and it's an underused resource.
So we've been working at this honestly since 2005, which is why I made the comment about becoming very patient. I do think in Australia you have the benefit of all of our mistakes. You don't have to take that long, but you probably do want to identify the change, or at least the future state that you would like to attain, and then move forward intentionally that way, and not wander about a bit like we did. But as I would say Massachusetts is one of the top 3 states in the United States for value-based care by the definition of how much money are you spending and is it worth the money? And it is all, so it's Massachusetts, Vermont, and Hawaii. We vie for top 3 every year. And it's because we have made these significant system investments in addition to trying to be a little piece of Australia and have universal access. So I would say it really, the power of a system change, and again, I'm so excited that this debate on enrollment is starting, and I'm going to really pull up my popcorn and enjoy watching the debate within your country. I don't know if it's the answer. I just know at least it's something different than business as usual, because I genuinely am a little sad at the end of this panel at how hard everyone is working and how little value is being felt still by the people that we actually have devoted our lives to, our patients. And so I look forward to change. It's probably going to involve some error. It always does. And I think something has to change. COVID, I think, has made that clear for all of us, but I'm feeling it in your context today. And I do want to give you any energy I have left to be able to go forward. And bring your patients in, bring your teams in, bring health coaches in. We can't do everything as GPs. That's, I think, the thing I want to say is I know that now, and I'm a stronger, better GP because I don't try to do everything now.
So thank you, everybody. There is a future for primary health care, but we're going to have to work hard and things are going to have to change. I think the forum this evening has actually introduced a number of important topic areas that I think the PHN will look forward to developing some interactive, both education but also consultation sessions in over the next year. So thank you very much, everybody.